All good, Amanda? Excellent. Okay, so thank you, everyone. So we've got Dr. Zoe Brown presenting today, and she's undertaking a PhD in the field of PAH in patients with systemic sclerosis, with a focus on the evaluation of screening for the early diagnosis of PAH. Her PhD involves the implementation and evaluation of a novel screening algorithm and the Australian Scleroderma Interest Group algorithm to detect PAH early using annual respiratory function tests and the blood NT-proBNP, which I'm sure Zoe's going to explain to us. So Dr. Brown is collaborating with pulmonary hypertension specialists in Queensland and Victoria on this research, and has worked in a shared rheumatology-cardiology clinic at St. Vincent's Hospital in Melbourne. And it gives me great pleasure to welcome you today, Dr. Zoe.
Thank you. Thank you so much for the introduction and for inviting me to speak today. I'll just open up my slides. Is that working for everybody?
Perfectly.
Excellent. Well, thank you for inviting me to present today about pulmonary arterial hypertension. These are my disclosures. We're very fortunate to have some funding support from Janssen, who I think has a representative here this morning. And I thought I would briefly, although I'm sure most people know about the Australian Scleroderma Interest Group, or ASIG, which is a collaboration of rheumatologists and immunologists and some other specialists. We've recently got a geneticist from Queensland who's collaborating with us, whose primary objective is to undertake research in order to improve outcomes for people with systemic sclerosis. And part of this is through the establishment of the Australian Scleroderma Cohort Study, which it facilitates yearly screening for heart and lung complications and is delivered in screening centres around Australia. And if people consent to participate, we have a longitudinal observational cohort, which has produced lots of valuable insights into scleroderma and has resulted in collaborations with other Australian researchers and researchers internationally. Today, I thought I would cover the definition of pulmonary hypertension, a little bit about scleroderma and pulmonary hypertension, how the condition is diagnosed and treated, and if we have time at the end, a little bit of talk about the research that we've been undertaking with ASIG regarding screening in order to make an earlier diagnosis of pulmonary hypertension. So firstly, what's the definition of pulmonary hypertension? Well, pulmonary hypertension means that there is high or elevated blood pressure in the blood supply to the lungs. The blood vessels in the lung circulation can become stiffened or narrowed, and the heart must work harder to pump blood through the lung circulation, which leads to enlargement of the right side of the heart or the right ventricle and reduces the heart's ability to pump effectively. The onset of pulmonary hypertension generally is quite slow, and the symptoms, which can include reduced exercise tolerance and shortness of breath, are often attributed to other conditions that people with scleroderma might have, such as interstitial lung disease or even anemia sometimes. And previously, this has resulted in a diagnosis of pulmonary hypertension sometimes being made after a person has developed more advanced symptoms of pulmonary hypertension. And older studies have shown that there has been traditionally up to a 2 to 4 year delay in the diagnosis of pulmonary hypertension. Having said that, though, this is perhaps more particular among the general population, where pulmonary hypertension occurs in less than 1% of people, and it's often not the most common cause of breathlessness, so it's often not thought of until other diagnoses have been ruled out. And some of the data about the delayed diagnosis also includes people from the general population. So how does pulmonary hypertension start to happen? The increased pressure in the lung circulation in pulmonary hypertension can be caused by quite a number of things. And in Australia, amongst the general population, the most common cause of high pressure in the pulmonary circulation is actually due to heart disease and coronary artery disease. The second most common cause in the general population is lung diseases like emphysema, and also sometimes interstitial lung disease. And the third most common cause is pulmonary arterial hypertension, which includes pulmonary hypertension that occurs in people with connective tissue diseases, the most frequent of these being scleroderma, and also an idiopathic or heritable form of pulmonary arterial hypertension. I guess one of the less frequent causes is pulmonary hypertension that can develop as a complication of having blood clots in the lung circulation or secondary to having pulmonary emboli. Data from the Australian Scleroderma cohort study has revealed that 1 in 10 people with scleroderma are currently living with pulmonary arterial hypertension or PAH, and 1% of people with scleroderma are at risk of developing PAH each year. Data from our cohort study has also shown that in the majority of people, PAH developed more than 4 years after a diagnosis with scleroderma. And this image is taken from the most recent international guidelines for the diagnosis and management of pulmonary hypertension, which were published last year. And it shows the classification of these groups that we have just discussed, with PAH due to associated conditions, which include scleroderma on the left, and the other causes following heart disease and lung disease. And as you can see, each of the distinct groups have different treatments which are recommended, and the diagnosis of differentiating between these conditions is what requires specialist interpretation of the results of a diagnostic test called a right heart catheterization test, and also investigations such as lung CTs or other lung imaging. And you can see here that the left heart disease is by far and away the most common cause, including the general population. The underlying mechanism of the high pressure in PAH related to scleroderma is different to that observed due to heart disease or lung disease, and it's more closely related to the idiopathic form of pulmonary hypertension and the heritable form. And so this diagram represents some of the changes to the lung circulation or the blood vessels that can be seen in people with PAH. This is a cross-section of a normal lung vessel at the top, and in some cases, the changes that lead to high blood pressure are this thickening or stiffening of the blood vessels. And a narrowed vessel means, a blocked vessel means that there's more resistance to the blood flow, which results in the higher pressure. This would be similar to if you put your finger over the end of the garden hose and the remaining jet of water that comes out is under much higher pressure. Whereas when pulmonary hypertension develops due to heart disease, which is the most common cause in the general population, the left side of the heart might be damaged due to coronary artery disease, and then it doesn't pump out blood to the rest of the body as effectively, and this results in transmission of pressure back into the lung circulation. And when pulmonary hypertension occurs due to lung diseases such as emphysema, the inflamed lungs affect the neighbouring blood vessels, causing them to become stiffened and narrowed, resulting in the increased pressure. And these two forms of pulmonary hypertension are treated quite differently to PAH, usually without the vasodilator therapies that I will speak about today. So how is PAH diagnosed? This is perhaps a good time to discuss screening compared to diagnosis. So screening tests are applied to an asymptomatic or healthy population in order to make an early diagnosis of the condition of interest. For example, the use of mammograms to screen for breast cancer. Screening tests are usually non-invasive and readily accessible, whereas diagnostic tests such as the right heart catheter test in PAH are needed at the time of wanting to confirm the diagnosis, and they're often more specialized. As I mentioned previously, waiting for the symptoms of PAH to develop can sometimes result in delays to make the diagnosis and delays to starting treatment, and that's mainly due to the non-specific nature of the symptoms. But there is evidence from studies locally and internationally that suggests that starting treatment earlier results in better outcomes. And as we know that pulmonary hypertension might affect up to 10% of people with scleroderma, compared to less than 1% in the general population, there is a unique opportunity to proactively screen people with scleroderma in order to make an early diagnosis before the symptoms develop. In 2018, there was a World Symposium on Pulmonary Hypertension, and this resulted in the production of updated international guidelines, which subsequently recommended yearly screening for PAH for all people with scleroderma and scleroderma-related conditions like mixed connective tissue disease and sometimes lupus in order to make an early diagnosis of PAH. So what might screening look like? The international guidelines currently recommend screening yearly, which could include transthoracic echocardiography alone or in use with the combination of respiratory function tests and the blood test called NT-proBNP. Currently in Australia, the NT-proBNP blood test is not reimbursed by the Medicare benefits scheme for routine use and yearly screening. However, from the 1st of November this year, the cost will be covered for a once-yearly test as part of screening in people with scleroderma, which we're very excited about. The outcomes of screening for pulmonary hypertension have been evaluated using data from large cohorts of people with scleroderma in both Australia and in France, and people who underwent screening, which resulted in a diagnosis of pulmonary hypertension, their outcomes were compared to people who were diagnosed with pulmonary hypertension through routine care or only after developing symptoms. And those diagnosed through screening had less severe pulmonary hypertension at the time of diagnosis and improved survival. And this data comes from one of the drug trials called the Griffin trial, and it compared treatment for PAH, which is a new treatment called selexipag, in the red line, compared to placebo on top of background therapy on the blue line. And in this analysis, the response to this new treatment was compared firstly in graph A, in people who the time from their diagnosis to starting treatment was less than 6 months, compared to those in B who had a longer time from diagnosis with PAH to starting treatment of greater than 6 months. And in those who started treatment early, the benefit of the new treatment selexipag to reduce pulmonary hypertension was more significant compared to placebo and background therapy when they were treated earlier, compared to people who started treatment more than 6 months later, where the lines track closer together, suggesting that earlier treatment resulted in a bigger improvement with the new treatment. This trial was performed in all people with PAH, so it included people with that idiopathic or heritable form, and it included around 30% of people with connective tissue disease associated pulmonary arterial hypertension. And the majority of that group would be people with scleroderma. So if your doctor suspects pulmonary hypertension on the screening results, they may refer you to a pulmonary hypertension specialist and arrange for further investigations, including a heart ultrasound or echocardiography to evaluate the heart size and function and to make an estimation of the pressures in the pulmonary vessels, as well as respiratory function tests, which can also give signs of pulmonary hypertension, and sometimes other tests like the 6-minute walking test. In order to confirm the diagnosis, the gold standard investigation to make a definitive diagnosis of pulmonary hypertension is the right heart catheterization test. A right heart catheter is performed as a day procedure at a hospital, during which a very fine catheter is inserted via blood vessels in the arm or the leg up to the pulmonary artery or the pulmonary vessels. And here we're able to make an estimation of the pressure in the lung circulation, but also to evaluate the heart size and function to decide whether the elevated blood pressure is truly due to changes in the blood pulmonary vessels, or if it could be that more common cause of the left heart disease. And so if the right heart catheter confirms PAH or pulmonary arterial hypertension, what treatments might be suggested? There have been significant advancements in the treatment of PAH over the last 25 years, and it's been a very exciting time to work in this space, actually. This graph represents over 40 clinical trials from the 1990s up to 2018, and these have all been investigating treatments for PAH. Over the last decade, we've started to see these trials in red and blue, which represent the evolution of our treatment strategy, which now includes looking at combination therapy, in which people with moderately advanced pulmonary hypertension might receive treatments with 2 treatments started sequentially, or as upfront dual combination therapy at the time of diagnosis. And these are now the recommended treatment strategies used in Australia to achieve the best results. The current treatments for pulmonary hypertension primarily target this vasoconstriction or narrowing of the blood vessels. And there are 3 chemical pathways that control the opening and closing of blood vessels. Nitric oxide and prostacyclin signal the vessels to open or to vasodilate, whereas endothelin signals the vessels to narrow and shrink down. By increasing the actions of nitric oxide and prostacyclin, medications promote vessel opening to reduce the pressure, making them look more like this normal vessel. And by blocking endothelin, medications are able to prevent the narrowing and promote vessel opening to reduce pressure. The initial approach to the management of pulmonary hypertension includes other general measures, including advice regarding physical activity and enrolment in supervised pulmonary rehabilitation programs with physiotherapist support, as well as sometimes supportive or adjunctive therapy, which might include other cardiovascular medications like anticoagulants or diuretics for fluid balance management, and sometimes supplemental oxygen. It may also involve referral to different specialists at an expert pulmonary hypertension centre in association with your usual treating doctor. The first-line oral medical therapy available for people with pulmonary hypertension in Australia includes the oral phosphodiesterase 5 inhibitor tablets, such as sildenafil and tadalafil, and the endothelin receptor antagonists, such as macitentan and bosentan. And the oral treatments for pulmonary hypertension have been shown in those range of clinical trials that we saw before on the graph to improve exercise capacity, to improve the heart function, and to reduce the pulmonary pressures and improve survival. The oral phosphodiesterase inhibitors, sildenafil and tadalafil, they work on that nitric oxide pathway to open up the blood vessels, and they're also thought to have some effects to improve heart function and to prevent the thickening of the blood vessels. As these medications cause blood vessels to dilate, they may cause flushing, and they can sometimes lower the systemic blood pressure. They can also sometimes cause headache and gastrointestinal upset in some. The other available tablets are the endothelin receptor antagonists, such as macitentan and bosentan, which act to block endothelin from constricting or narrowing vessels. And similar to the phosphodiesterase 5 inhibitors, they may also cause signs of vasodilation, such as headache. And whilst people are taking these medications, they will require monitoring of regular blood tests. The third pathway is the prostacyclin pathway to open blood vessels, and previously the only treatments available acting through this pathway were by continuous intravenous infusion or by a nebulized route. However, there is a new oral tablet called Selexipag, which works to open the blood vessels using the prostacyclin pathway. Selexipag has similar side effects to the other medications due to its effect as a vasodilator, including reduced blood pressure or headache and some gastrointestinal upset. And so Selexipag is usually started at a very low dose and gradually increased to find the appropriate dose without causing side effects. And often that's done in association with a pulmonary hypertension nurse. This flowchart is taken from those international guidelines, and this has been produced on the basis of research that suggests that a comprehensive assessment to stratify pulmonary hypertension as low, intermediate, or high risk at the time of diagnosis should guide the treatment choices with either single or dual therapy, and that by basing the treatment choices on this assessment of risk results in improved symptom control, increased exercise capacity, and improved outcomes. People with low or intermediate pulmonary hypertension might be commenced on one oral pulmonary hypertension therapy with a view to the addition of a second agent after 3 to 6 months if necessary. And people with high-risk pulmonary hypertension might be commenced on 2 tablets or intravenous treatment up front. And we know from our cohort that people are living longer with PAH, and there's lots of work being done in this space. However, one of the most important things is to detect and treat PAH early. If there's a little bit of time still, I'd like to talk about the research that we've been doing in Melbourne. So in particular, we've been focusing on ways to improve screening and to improve access to screening for people with scleroderma. I think we've been quite fortunate in Victoria that there are a few people spread out through the state who do have an interest in scleroderma. However, in places like Queensland, there's more difficult access to specialised testing such as echocardiography and also the interpretation of those test results. And as a result of this, there is some evidence that shows that yearly echocardiography alone can sometimes miss a diagnosis of pulmonary hypertension because of an inability to make the measurement of the blood vessels, which does take some practice in order to be able to do. Echocardiography is also an expensive and timely test, and it can be difficult to access for people in regional and rural areas. Dr. Thacker is a rheumatologist who worked with ASIG to investigate the performance of screening for pulmonary hypertension using a combination of just lung function tests and that blood test, the NT-proBNP. NT-proBNP is a blood marker that's released from the heart when it's not working properly or it's under strain. And Dr. Thacker found that the NT-proBNP levels were the highest among people with a confirmed diagnosis of PAH, but they were also higher in people who were at risk of PAH or who had very early pulmonary hypertension compared to people with interstitial lung disease or compared to people with scleroderma with no heart or lung complications. He also found that by combining the blood test with the results of lung function testing, further improved the ability to identify the presence of pulmonary hypertension. So from the results of Dr. Thacker's work, we've developed a screening algorithm that involves yearly lung function testing and the blood test for NT-proBNP. And if either test returns as positive, a person is then referred for echocardiography rather than all people having an echocardiogram every year. If neither the lung function test or the blood test are positive, people are able to be screened again the following year. And the ASIG algorithm has been compared to annual echocardiography alone, and it was shown to be more accurate in identifying pulmonary hypertension and to result in cost savings if echocardiography is then only used for people with a positive screening result. However, this analysis so far has been performed retrospectively using data from people enrolled in the Australian Scleroderma cohort study, and it has been on the basis of this work and ongoing work to evaluate the ASIG algorithm prospectively that the NT-proBNP has had the successful application to MBS for now funded use as part of screening in scleroderma. So what we hope comes from this work is an increased awareness and understanding of PAH and pulmonary hypertension, and improved access to screening throughout Australia. We would really like to promote early identification of those with possible PAH and referral to an expert centre for further investigation and management. Hopefully this has helped to describe pulmonary hypertension in scleroderma and to introduce some of the concepts underpinning screening and early treatments. I would like to thank everyone in ASIG, members and participants, and also our funding support through Janssen. And I'd just like to mention the Lung Foundation website for anybody looking for more information. It really is an excellent resource, both for pulmonary hypertension, but also other lung diseases. And hopefully this will allow us a bit of time for questions.
Yes, brilliant. Thank you so much, Zoe. That was great, very informative, and I know that we've got lots of questions. Amanda, did you want to chat about the patient charter first before we go into some of the questions?